by Pierre Rival for this case. So, the case is about a woman. She's 37 years old, and she was coming to the emergency room because of shortness of breath. She is a drug addict, and she's HIV positive. So, she started 6 months ago an antiretroviral therapy. She was referred for CT angiography by the emergency room because they suspected PE. So first, we have the chest X-ray. I am going to let you a few seconds to look at the pictures. Do you have an idea about the diagnosis? So the chest X-ray. Here first you can see the patient was sitting in bed. So you can see the intensity of the dyspnea. Next, you can see this line, this convexity of the line of the left mediastinal border. It's abnormal, and it's a sign of an enlargement of the main pulmonary artery. You can see there is no cardiomegaly, no pleural effusion, and there is enlargement of pulmonary arteries. Next, the CT angiography. So first, you can see there is no intraluminal thrombi, so there is no pulmonary embolism. Next, you can see the enlargement of the main pulmonary artery and of the right and left pulmonary arteries. The diameter of the main pulmonary artery is bigger than 29 millimeters, and it's bigger than the diameter of the ascending aorta. Here you can see the hypertrophy of the right ventricle, the enlargement of the right ventricle and the right atrium, the smaller left ventricle, and the deviation of the interventricular septum. You can see there is no pleural effusion, no mediastinal lymphadenopathy, and in lung parenchyma you can see there is no mosaic attenuation, no ground glass opacities. There is no emphysema, so there is no lung parenchyma disease underlying. Here you can see the severity. There is big enlargement of the right ventricle, of the right atrium, the deviation of the interventricular septum to the left, and the compression of the left ventricle. So it's due to the very high pressure inside the right ventricle. So do you have an idea about the diagnosis now? Yes, it's a pulmonary arterial hypertension due to HIV infection. So it's the classification of pulmonary hypertension. It's the last classification from December 2013. There are 5 groups. One, unclear multifactorial mechanisms. One, chronic thromboembolic pulmonary hypertrophy. PH due to lung diseases or hypoxia. And one, left-sided heart diseases. There is no sign in our case about this group. So there is the group 1, pulmonary arterial hypertension. It's a diagnosis of exclusion. It's like idiopathic, inherited, like BMPR2, ALK1 mutations. It can be drug and toxin induced, like anorexigens agents, and it can be associated with connective tissue disease, like systemic sclerosis. It can be due to HIV infection, portal hypertension, congenital heart diseases, and schistosomiasis. You have too the pulmonary veno-occlusive disease and the pulmonary capillary hemangiomatosis. It's important to differentiate these two etiologies to the other PH because the specific therapy of PH can be dangerous for these patients. It can induce a fatal edema, and they need a lung transplantation. So here, it's HIV infection, because the patient was HIV positive, and it belongs to the group of the pulmonary arterial hypertension. So here you have the French National Registry of 674 patients. You can see it's a woman-prone disease. We talk about the group 1 pulmonary hypertension. So it's a woman-prone disease. The age is about 50 years old. The idiopathic form is one of more common of PH, about 40%, and the HIV infection is about 6%. You can see that in group 1 of pulmonary hypertension, that is to say idiopathic inherited due to HIV or anorexia, there is no specific CT features. There is only vascular and cardiac signs, that is to say the enlargement of the main pulmonary artery is greater than 29 millimeters, and it's bigger than the diameter of the ascending aorta. And you can see the enlargement of the right ventricle, right atrium, the deviation of the septum, and the smaller left ventricle. Here it was a case of an irritable PAH in 30 years old woman. And you can see it's the same signs like how PH due to HIV. So the pulmonary hypertension due to HIV infection, the first case was reported in 1987, and since we have more than 200 cases reported. The prevalence in patients with HIV is about 0.5%, and it could be 10 times higher if asymptomatic patients considered. We have the same microvascular lesion as in idiopathic form. We don't know exactly the mechanism of the HIV and why patients develop a PH, but we know that there is an indirect role of the virus and probably genetic susceptibility or additive factors. For example, the VIH negative factor induces proliferation of pulmonary endothelial cells. That protein represses the transcription of BMPL2, and the HIV glycoprotein 120 induces vascular smooth cell proliferation. But there is no mutation for BMPL2. So the treatment. PH persists despite the antiretroviral therapy, so it requires a PH-specific therapy. And it's necessary to know that in very severe PH, it can be deleterious to perform a CTPA. For example, in this case, the patient had a very enlargement of the right ventricle and the compression of the left ventricle. And the contrast administration, it was dangerous because patient had a heart attack after the CT. So what is the take-home message? Look at the chest X-ray. Because you already had the sign of PH with enlargement of the main pulmonary artery. Thank you very much.